Hi, my name is Beth Surratt. I am the Stemi coordinator at Lake St. Louis, and today's topic is Stemi case reviews. First, let's talk about inferior STEMIs. This is a STEMI where the inferior wall is damaged. You will see in leads 2, 3, and AVF view of the inferior surface of the left ventricle. This portion is perfused by the descending branch of the RCA, and the patient will display nausea and vomiting, possibly due to the overstimulation of the vagus nerve. You will see reciprocal changes in the lateral leads of E1 and AVL. This EKG is an example of a 100% occluded right coronary artery of a patient that was brought in. As you can see by the EKG, that you will see ST elevation in leads 2, leads 3, and AVF, with ST depression in lead 5 and 6. This is the occlusion that we found per angiograph of the right coronary artery. As you can see, it's completely occluded there. After we performed balloon angioplasty and stenting, we opened up the vessel, and you can see it goes quite nicely open. This is another example of an inferior STEMI on the EKG. Again, you'll see ST elevation in leads 2, 3, and AVF. So you go. Here's your elevation, and there's AVF. And then you're also going to see reciprocal changes of ST depression in leads 1, right there, AVL, here's your depression, V5, and V6. This is another example of an inferior STEMI with an EKG that's pretty classic. Again, you're going to have ST elevation in leads 2, 3, and AVF. This was the example that I've shown during the cardiac catheterization. We had 100% occlusion of the RCA. You can also see some calcification going down there. After we opened the vessel with the drug-eluting stent, you can see here in this, the stent, you can see it kind of right in this area. We got good flow and reperfusion after the cardiac cath. The next type of STEMI I want to talk about is anterior STEMIs. An anterior wall myocardial infarction will have involvement showing EKGs in lead V3 and V4 that face the anterior wall of the left ventricle. This area is mostly perfused by the left anterior descending, also called the LAD. You may see reciprocal changes in the inferior leads, but those are usually pretty subtle. This here is an example of this with this EKG. You will have elevation in leads V2 through V6, also in lead 1 and AVL. And we will look right here. You're going to see V2, V3, 4, 5, and 6 all have elevation in the ST segments. Also with lead 1, you're going to see that there, as well as your AVL lead. And you'll see that right here. You're kind of seeing ST elevation throughout the entire EKG. You will see in AVR, you're going to see some ST depression, and you're also going to see some T-wave inversions in lead 3 and AVF. And here's your inversion there, and your T-wave inversion there. This is the angiograph picture of the STEMI. You're going to see 100% occlusion of the LAD, as you can note right there. It's completely stumped off. And then this is the end result after putting the stent in, and it's nice and open there with a lot of reperfusion. And those are the images of before and after the cardiac cath. This here is an EKG showing a right bundle branch block with ST elevation MI. You're going to see uh, ST elevations in lead V1 through V6, as you can note here. There's V1, V2, 3, 4, 5, and 6. And then you're going to note over here on lead 3, you're going to have some T wave inversion and a biphasic here on AVF. And this here you're going to note on the angiograph that the LAD was 100% occluded. And then this is the after we place the stent during the cardiac cath, and you're going to see how much reperfusion they have after the stent is placed. This next example is a posterior MI EKG, and what you're going to see on this example is ST depression in V1 through V3. And you can see, as the arrows indicated, there is your ST depression. And that's because it's in the posterior side, there you go, of the heart. You're going to see that depression in those leads V1 through 3. And these are the slides that you see here where the posterior MI Stemi was brought in. There was 100% occlusion of the circumflex, as you'll see in the image there on the first slide. The middle slide is another view, and then the third slide here is the after we put the drug-eluting stent, and you can see that it is open again. On this slide here, I just wanted to remind people that if you see ST depression on its own in V1 through V3 in patients with symptoms of ACS, you should always consider doing a 15 lead EKG if possible. A 15 lead EKG is helpful when a patient has either an inferior or especially a posterior MI with ST depression in V1 through V3. This can suggest a right ventricular MI, which is a more larger and more complicated inferior MI. Additional leads like the 15 lead are used to show the view of the posterior surface of the heart. Posterior MI, you'll see reciprocal changes such as ST depression in V1 and V2. You will also possibly see tall R waves. And that may be all you see in this. And then this diagram here is just to show you of and remind you of the placement of your leads. Basically, all you do is you move your leads to the behind the left scapula there, and that will be your leads V7 and 8. And if you recall, you have V1 and 2 your typical places, as well as 3, 4, 5, and 6. And then the only leads that are changed to the back are 7, 8, and 9. Always remember to label your EKG that it is a 15 lead EKG. Another type of STEMI is a septal wall STEMI. And this includes basically the leads V1 and V2 that face the septal area of the left ventricle. The septum contains the bundle of His and the bundle branches. This can cause new bundle branch blocks, second and third degree heart blocks. It is usually perfused by the LAD and partly the right coronary artery. If ST depression is in V1 and 2, remember this could also be a posterior MI. This EKG here shows the septal wall infarct with the left bundle branch block. And you will see there in your V1 and V2 leads the elevation there. And this again in this EKG is just another example of your elevation in V1 and V2. This is actual imaging of a patient that was brought in with a left bundle branch block that arrested, um, I believe, at a dialysis unit. He came in with a new left bundle branch block in full arrest. And basically, what we found, he basically had triple vessel disease. But as you can see, the before and after pictures here, you can see the LAD was occluded. He had blockages just everywhere. They ended up stenting that. We placed an Impella device, as you can see there. He also had occlusions in his right coronary before and after. This patient ended up after a 30-day course of being in the hospital, um, eventually going home and recovering. Another type of STEMI is a lateral wall STEMI. You will have in leads 1, AVL, V5, and 6. That's where you're going to view the lateral wall of the left ventricle. This portion is usually perfused by the circumflex artery, but may be also perfused by the LAD or the RCA. You're going to see reciprocal changes in inferior leads of 2, 3, and AVF. This EKG is an example of the lateral wall STEMI. Again, you're going to see the ST elevation in lead 1. You can see there. Lead AVL, you can see those elevations. V5 and V6. You're also going to see ST depression in your V leads there. These here are images of the angiograph of the STEMI, and you're going to see that was a lateral wall MI with a large circumflex obtuse marginal branch with a thrombus in it. So you can see here, this is pretty clamped down right there. You can see it's hazy. Here, right here is the thrombus in the obtuse marginal of the circumflex. And then this is the after pictures after the drug-eluting stent was placed and the thrombectomy device was used. And this picture here was the actual clot that was retrieved from the obtuse marginal. It was a huge clot that we took out and retrieved from that and opened it up. This slide is a reminder of our first medical contact to reperfusion times according to the TCD, which is time to critical diagnosis. Our goal is less than 90 minutes. The best times that we see are with EMS that spend less than 10 minutes at the patient's side before transporting that patient to the hospital. Pre-activation in the field and transmitting the EKG to the ED, which allows the cath lab to be activated from the field. Reminding you guys that the cath lab does have 30 minutes if they're not in hospital to respond and to get to the hospital. So if you activate it quickly, usually we can meet you in the ED if we're activated quickly. And remember, arriving to the closest PCI capable facility is best practice. We often see fallouts if there's extended times at patient's bedside prior to the transport. Always remember, grab and go is the best. Not transmitting the EKG in a timely manner. Poor communication or report, meaning if it's not activated as a STEMI, if you're waiting to 6 minutes prior to calling report that you have a patient, that's going to set us back because we still have to set up and arrive at the hospital. Another issue we have noticed is that sometimes the ED isn't activating the cath lab in a timely manner. So we're working diligently with the ED to activate those STEMIs. And we're also working with LifeNet and getting those capabilities to send those and transmit those EKGs to our cardiologists to activate them more quickly. Remember, documentation is key. Please note, time of STEMI was called for our tracking purposes so we can see whether it's the EMS not activating and sending the EKG, or if it's the ED department. We track all the charts and try to find out where the faults are just to make our hospital and our EMS better for better outcomes for patients. Remember, time is muscle, so activate quickly. Teamwork makes the dream work. Thank you for all you do, and together as a team, we're going to provide the best care for our patients.